Shai Fuchsman. I am with the Education Development Center, and I'm also a senior advisor with a collaborative behind the summit. We are going to wait just a minute or two before we formally start, just to let other participants join us. But just wanted to say a quick hello and welcome to those of you who joined us early. And if you would like, feel free to introduce yourself in the chat. Tell us where you're joining us from today and what is your role. Feel free to do that while we wait for others to join. We'll give another minute or two before we formally start the keynote. I've seen a couple of people join us. Just wanted to say a quick hi and welcome to the keynote. Just want to make sure you all know you're in the right place. I've also noticed that a few people have introduced themselves in the chat. So welcome to you all, Heidi and Kay and Cynthia and Jan. For those of you who have not introduced yourselves, feel free to do that as well. If you don't mind, let us know where you're joining us from today. And what is your role? I'll wait for maybe one more minute to join. To get started with today's keynote. Welcome, Lori. And we'll get started in just 1 minute. Okay, so it's about 2:45 Eastern time where I'm at, so I'm gonna get us started. So welcome everyone to the keynote for today's summit. It's been a very interesting and engaging summit up until now, and our speaker today will help add to that, to this conversation we're having about supporting students impacted by trauma. My name is Shai Fuchsman. I'm a senior research scientist with the Education Development Center. I'm also a senior advisor for the REL Appalachia Cross-State Collaborative behind the summit. And it is my pleasure this afternoon to introduce our speaker, Michael Mead. Before we do that, next slide. I know we're all very familiar with Zoom, but at this point, but I just wanted to encourage you all to make use of the functions that we have available. Feel free to use the chat. I know some of you have already done that. Thank you for participating in the chat. And for those of you who haven't, feel free to do that. If you have any questions, please add them to the chat. You can select to all panelists and attendees so that everyone, if you want to send a message to everyone, put all panelists and attendees so everyone can see it. If you have a question, please add it to the Q&A button on the bottom of the screen, and we'll make sure that those get addressed at the end. Closed captioning is also available. You can click on closed caption on the bottom of the screen, and then click on show subtitle. And we will be posting the recording of today's session and slides following today's summit. So with that, I want to introduce our speaker, Michael Mead. Michael serves as the Director of Research and Programs for East Tennessee State University's Center for Rural Health Research, a mouthful. He's also a senior fellow at the NORC at the University of Chicago Public Health Research Department, another mouthful. And he's also the Deputy Director of the Rural Health Equity Research Center, which is funded by HRSA, the federal department agency. And it's a partnership between ETSU, or East Tennessee State University, and NORC. Through all these appointments, Michael leads research and programmatic activities in the areas of opioid and overdose mortality, rural health, and public health systems, while leveraging synergies between NORC and ETSU research agendas to develop collaborative research initiatives. He's going to be talking to us today about the trends in opioid use for the past several years, and the implications for the work that we do to support students impacted by trauma. So with that, I'll turn things over to Michael.
All right, thank you very much. So go on to the next slide, please. So this is an overview of what I want to cover today. So I'm going to share a lot of data with you. I might go through it a little bit quickly. So if anybody has any questions, please add them to the chat, and we'll try to get to those at the end. But I'm going to talk about opioid-related trends, both in the United States, but in particular within our Appalachian region. And then I'm going to talk about ACEs, adverse childhood experiences, and in particular, the intersection between opioid misuse, COVID-19, and ACEs. And then I'm going to end with some strategies for addressing trauma and promoting resiliency in schools. And in particular, I'm going to end with a short video that some of my colleagues created, really introducing another center at ETSU, which is our Strong Brain Institute. And that is an institute within ETSU. It's a collaboration between a number of departments within ETSU to focus on adverse childhood experiences. Go to the next slide, please. So this is really what we're here to talk about. This is data on drug overdose deaths. So on the left, you see the total drug overdose deaths between 1999 and 2019, which at the time of the slide was the most recent data available. And you see this rapid increase. I'm going to talk a little bit about what accounts for that increase. But again, on the left, you'll see that men have higher overdose rates than women. But notably, and I'll show this later as well, women in Appalachia have a much higher disparity as compared to women in the rest of the country. So the disparity is greater for women in Appalachia, even though the rates are higher for men in Appalachia. And then on the right, and this is something I'll come back to when we talk about Appalachia as well, but I really want you to focus in on those three graphs that are the highest. So what you see here is that the people most affected, and this is national data, but this is true in Appalachia as well, the people most affected by opioid overdose are between the ages of 25 and 54. Why is that notable? Well, one, those are people in their prime working years. So this has economic implications for our nation and for our region, but these are also people of childbearing ages. So these are people with young children. So when we talk about that intersection between childhood trauma and drug overdose, this is why this is so important. It's really affecting people who are likely to have children. Next slide, please. So this is a slide that's produced by the Centers for Disease Control. And this really shows what CDC refers to as the three waves of the opioid crisis. So if you look at the beginning, 1999 on up to 2010, what you see here is really the prescription drug crisis, which really started this whole issue of opioid overdose. Around 2010, states got smart, or at least they thought they got smart, and realized that the driver of drug overdoses was prescription drugs. So they clamped down on access to prescription drugs. They did so, however, without addressing the underlying addiction. So if people are addicted and no longer have access to prescription drugs, they're going to find something else. And what they found, unfortunately, was heroin. So then you see this second wave. And unfortunately, heroin is much more deadly than prescription drugs. It's much less controlled than prescription drugs. So you see this first spike in that second wave. And then around 2013, we saw the introduction of synthetic opioids. So fentanyl, carfentanil. And this made the heroin that it was being laced into even more deadly. And then we see this third wave. So what we end up with looks very much like an epidemic curve, but it really comprises three waves, each wave of which was more deadly than the prior. And in total, what we see is that in 2019, opioid overdose deaths were over 6 times higher than they were back in 1999. Next slide, please. So how many people are using substances or misusing substances? So this is data that comes from the National Survey on Drug Use and Health. So this survey is a population survey to try to understand the number of people in the past year who have used illicit substances. And what we see is that 21% of people responding to this survey reported illicit drug use in the past year, And of that 21%, the majority were users of marijuana, but you see that the second most frequently used substance was prescription pain relievers, opioids. Next slide, please. And then this slide essentially shows a similar sort of trend for youth. And this comes from the YRBS, the Youth Risk Behavior Survey. Again, another population survey of youth to find out the prevalence of substance misuse among youth. And what we find with the YRBS data is that 14% of youth report ever misusing prescription opioids. And then among high school students, about 7% report misusing prescription drugs in the past 30 days. And what we see is that this is particularly higher among females and among Black and Hispanic youth. Next slide, please. So this is a slide that starts to bring these things together. So what you see here, it's a kind of a busy slide, but what I want you to pay attention to are those counties in red. And you'll notice that Central Appalachia in particular is very, very red in this slide. Eastern Kentucky, West Virginia, Southwest Virginia, up into Ohio. What you see here is this intersection between drug overdose mortality and foster care entry. So these red counties are the areas that have high overdose rates and high foster care placement. And again, you see this concentrated in our region. There are other regions of the country that have been affected by the opioid crisis as well, which also are seeing high placements. But our region is certainly one of those regions where there's certainly a lot of concern about this intersection between drug overdose and foster care placement. Next slide. So this is also kind of a complex slide, so I'll tell you what you're looking at. But this is another way of looking at this same issue. So what we see in this slide is that for every 10% increase in drug overdose deaths, we see about a 4.4% increase in foster care entries. So again, every 10% increase in drug overdose deaths, 4.4% increase in foster care entries. Similarly, we see that for every 10% increase in drug-related hospitalization, we see a 2.9% increase in foster care entries. So again, these things really go together. We see drug overdose and foster care entry really going hand in hand. And that's not a surprise to any of you, I know, but this really helps to quantify the impacts that we see, particularly within our own region. Next slide, please. And then this is neonatal abstinence syndrome. And again, I know this is something that a lot of you are probably very familiar with. But again, here look at the top right map. So this map is the percent change in neonatal abstinence syndrome per 1,000 births. And this compares the difference between 2010 and 2017. And you see that the areas that have experienced the highest rate increase, again, are in our region, West Virginia in particular, but we also see Kentucky and North Carolina and Tennessee showing very high rates of neonatal abstinence syndrome increases over that 7-year time period. Next slide. So this is where I want to share with you a tool that we developed when I was at NORC. This is something that we continue to work on to this day, and we actually have an Appalachian version of this as well. So this tool, and I have it circled here, the tool is available, it's publicly available. It is at opioidmisuse.norc.org. If you're interested in the Appalachian version, which functions very, very similarly, the website for that tool is overdosemappingtool.norc.org. Again, they function very, very similar. And what this does is it creates a heat map where you can see the areas of the country that have had the greatest drug overdose mortality rates across a 5-year time period. So the data within this tool are from 2015 to 2019. And we do that so that we can report for the largest number of counties possible. Otherwise, we end up with a lot more, like you see in the middle of the country, which is gray, a lot of counties that the data are suppressed because the numbers are too small to report. So we pull 5 years of data, and what you see here is, again, a concentration of high incidence counties in central Appalachia. We also have high incidence counties in the northeast of the United States and in the southwest, but our region really continues to be a region that is disproportionately affected by opioid misuse. There are a lot of functionalities in this tool. I invite you to go in and play with it, access the data. I'm only going to share a few with you, though. If you go to the next slide. So to me, this is really the most important feature of the tool for all of you. So if you click on your county, you can pull up this data sheet for your county. This would be printed off. If you hit the print button, it'll print off as an 8.5 by 11 piece of paper that you can take to community meetings. If you hit the email button, it will populate it into an email. You can send it out to your stakeholders. But what it allows you to do, again, this is available for every county in the United States. It allows you to compare the drug overdose mortality rate in your county to the rate in your state to the rate in the nation. And if you were in the Appalachian tool, it also includes the rate for the whole Appalachian region. That's really the only difference between the Appalachian and national tool. But what you see here for Logan County, West Virginia, is that 5-year rate from 2015 to 2019 is 110 deaths, 110.8 deaths per 100,000. You can compare that to the state of West Virginia, which is 75.9. But you also compare it to the United States as a whole, which is 28.7 over that 5-year time period. So in Logan County, West Virginia, they have a drug overdose mortality rate that's about 4 times higher than the United States rate. And that's really what's important to know here. Again, you can access all this data for your own county. If you look down the information along the right side, you can also compare all of the data for your county to your state to the nation on various demographic factors, various socioeconomic factors, things that may associate to the opioid crisis within your community. In particular, you'll note here, for example, a high injury prone employment, which is a really important factor to consider because that is an entryway to people being injured and being introduced to opioids, which again can lead to this larger issue as people lose access to the prescription drugs and then move on to heroin. Next slide, please. So this I know looks similar, but what has been done here is we've shifted the view from the 2015 to 2019 data to the change between the 2 5-year time periods within the tool. And what you see here, again, for Logan County, is that across those 2 5-year time periods, the rate got higher. So the drug overdose mortality rate increased by 24.6 per 100,000 across that 5-year time period. And again, that's almost the rate of the nation as a whole. So in Logan County, West Virginia, their rate increased by almost as much as the rate for the nation as a whole. And then go on to the next slide. So this is also additional data that's within the tool. This is called our Prosperity Index. I want to introduce you to this. This is a little bit different, and it's something that we are continuing to build out and we'll be working on over the next year. What this does is it is a 16-measure composite index that looks at different types of economic and social risk and resilience factors, things that may be associated with higher rates within your community or higher risk within your community, where we want you to be have this data available to compare your county, again, to your state, to the nation on factors like poverty rates, like the number of nonprofit organizations per 100,000, the types of partners that may help you address the opioid crisis, the high school dropout rate in your community. All of these different factors that increase community level risk and resilience in your community. If you go to the next slide, this is just a slide. These are those 16 measures. They're a little bit easier to read here. And again, the Prosperity Index is a composite of these measures and strongly associate with health outcomes when they're pooled. So if you go one more slide, you'll see the map of what this looks like. So this is a map of all of the Prosperity Index scores for the United States for every county, 3,124 counties in the United States. And you'll see those dark orange counties are the counties with the lowest prosperity. So these are the counties in our country that struggle the most. And again, you'll notice that Central Appalachia is very overrepresented within this map, as are other high poverty communities within our country, our regions within our country, the rural South, the Delta region, the US-Mexico border region, and then up in the Plain States, you'll see Indian reservations. So all of these communities have something in common, which is low prosperity. And that unfortunately predisposes these communities for a lot of the challenges that we see, not limited to, but certainly inclusive of overdose mortality. If you go one more slide. So essentially, that's what I show here. So what you see along the x-axis is that prosperity index score. And then the dots here are the counties with the highest overdose mortality rates in the nation. So these are the strongest outliers for overdose mortality. And you see that almost entirely, the counties that are the largest outliers, the counties that have the highest overdose mortality rates, have the lowest prosperity scores within our tool. All right, go on to the next slide, please. So again, I promised I was going to hit you with a lot of data. So I want to jump into one more report. And I think particularly for our Appalachian region, this is probably the best data that is currently available. This is work that we did for the Appalachian Regional Commission. We initially did this study in 2017 using 2015 data, and we have since updated it using 2018 data, and that report was produced in October of 2020. And what we look at here are what are referred to as deaths or diseases of despair. This is terminology you may have heard. This comes from a couple of health economists at Princeton University who coined this term. But essentially what they're looking at are 3 causes of death that they associated with despair. That is overdose, suicide, and alcoholic liver disease. Now, I will tell you, this is not without controversy. There are some people who do not like this concept of deaths of despair. I personally am somewhat ambivalent about the terminology. I still think it's really helpful to look at these 3 causes of death, which are much more prevalent within our region, regardless of what you think some of those associated factors are. I think the issue that most people have with this idea of deaths of despair is that there are a lot of other causes of death that we may also associate with despair that may lead you to look at other population groups. So specifically, when we look at these 3 causes of death, we are focused then towards white working class populations, which are disproportionately impacted by these causes of death. But for example, if we were to look at things like gun violence, we would be led to different populations that are much more inclusive of communities of color. So I think that's part of the controversy. But again, setting that aside, I still think it's useful for us to be looking at these 3 causes of death. So let me walk you through this. Go on to the next slide, please. So this is data comparing what we found in 2015 to 2018. So as a whole, you will see that the disparity between Appalachia and the non-Appalachian US in 2015 was 37, and now it's 36. So this basically means that if you live in the Appalachian region, you are 37% more likely to die from one of these causes of death than if you live in the rest of the United States. So it looks like it's relatively stable between 2015 and 2018, but notably, the composition has shifted. So in 2015, you were 65% more likely to die from overdose. Today, or in 2018, that went down to 48% more likely. At the same time, suicide in the Appalachian region increased by 50% relative to the rest of the United States over that 3-year timeframe. In fact, it was a 2-year timeframe that actually showed up in the 2017 data. And alcoholic liver disease as a cause of death increased by about 50% over that 3-year time frame as well. Importantly, though, even though the composition shifted, I also want you to note that overdose mortality did not go down between these two timeframes. In fact, it went up. It just went up faster in the rest of the United States. So the disparity went down because everyone else got worse. That's not how you want to fix a disparity. So in the Appalachian region, our overdoses went up, but everything else went up even faster within our region. So again, if there were a clarion call on what we should be focused on within our region, I do think that these 3 causes of death would very quickly rise to the top. Next slide, please. So this, I alluded to this before, but we do not live in a monolithic region. Things differ within our region. I keep talking about Central Appalachia, and that's what you see in this slide. The deaths of despair are much more prevalent within our Central Appalachian region, actually relatively low in Southern Appalachia, which are also areas of high poverty. So there is something about the Central Appalachian region that distinguishes it for these different causes of death. Next slide. And I alluded to this earlier as well, but again, what we see here is who this is impacting in terms of males versus females. So the male rate is much, much higher. This is specifically overdose mortality. You see that in that 25 to 44-year age group, again, that is that age group that is in their prime working years and who are likely to have children. If you are male in that age group, you are roughly 50% more likely to die from overdose. If you are a female in that age group, you are twice as likely as females in the rest of the United States to die from overdose. Again, the rates for females are lower, but the disparity is greater. And the age groups that are being most impacted are the people who have children and the people who are at their working ages. It affects our children, it affects our local economies. Next slide, please. And just as with the overall overdose deaths of despair, we see that this varies widely across our region. We see Central Appalachia as kind of the nexus of overdose mortality, where these things come together. As a whole, in Appalachia, about 70% of the overdose deaths were caused by opioids. Next slide, please. So I always feel obligated when I talk about these issues to mention this because these presentations, frankly, get a little bit dystopic, and these are the articles that we see. So these are all articles from the Washington Post. I could have taken them from any urban newspaper in the country. When people describe our region, they usually talk about opioids, they talk about disability, they talk about poverty, they talk about lack of education, whatever it may be. Our region has a stigma issue, and these issues that we genuinely face increase the stigma that is experienced across our region, and unfortunately, I think, is internalized by many of the people in our region who don't think that they can have a better future. What is important here is that these issues, while they are a struggle in our region, they do not define our region. And if you go to the next slide, this is what I like to talk about. I like to also highlight all of the strengths and assets in rural America as a whole, but certainly within our region. So most of the people in our region are not addicted. Most of the people in our region are not in poverty. Most of the people in our region are not disabled. Yes, we have higher proportions, but by and large, our communities are still defined by assets of collaboration, community spirit, strong work ethic, innovation, and creativity. These are the things that we also need to highlight. And I would put it to you this way. If we believe in this concept of diseases of despair and believe that that despair is largely due to economic stagnation, which I think is probably true, we need to do a better job of highlighting why an investment in our region is a good investment. And if the only thing we talk about are the challenges in our region, nobody's going to invest, and it's going to be hard for us to dig our way out of this problem. Next slide, please. So having shared some of the positives, I'm going to shift gears a little bit and then talk about what all of this means for the children of our region. I'm going to talk about adverse childhood experiences, and these fall into three categories: abuse, neglect, and household dysfunction. Despite what I truly believe are the assets in our region, when we have challenges in our region that are related to substance misuse, many of our children are having experiences that do not place them in a good position for a positive, successful future. And we need to be intervening early to give our children the best chance they have to move forward. Next slide, please. So, and again, I'm probably not telling anyone anything you don't know, but early adversity has a lasting impact, and there is a dose response curve, so that the more adverse childhood experiences that a child has, the poorer their outcome is likely to be. So again, we need to intervene early. We need to prevent and mitigate to the best we can. Next slide. So how prevalent are ACEs? So this is data that comes from the Behavioral Risk Factor Surveillance Survey. So I'm giving you more survey data, population-based survey data. What we know through the BRFSS ACEs module, they do a specific module around ACEs. We know that 62% of people in the United States have experienced at least one adverse childhood experience, and 16% have experienced 4 or more childhood experiences. So again, this is a dose response curve. The people who have experienced 4 or more are much more likely to have negative outcomes as a result. When we look at those experiences, 28% report substance misuse and 28% report parental separation or divorce. These are the most common household challenges that people report related to adverse childhood experiences. Next slide, please. If you hit the button one more time, I think I've got some animation here. Yeah, so adverse childhood experiences, suicide, and overdose are all related. So we know that ACEs increase the risk of opioid misuse and overdose and suicide later in life. Hit the button one more time. We know that recent CDC work has shown that students who experience 5 or more ACEs are 15 times more likely to report opioid misuse than those experiencing no ACEs. One more time. We know that losing a loved one to overdose or suicide during childhood is an ACE that increases the risk of overdose or suicide for that child. And one more. We also know that experiencing trauma before the age of 18 is associated with increased odds of opioid misuse, and the odds of opioid misuse are 3 times higher among adults with 4 or more different experiences of trauma. If you go to the next slide, please. So how do we prevent ACEs? So these are the evidence-based strategies. We strengthen the economic supports to families. This is strengthening household income, making sure they're family-friendly places to work. We promote social norms to protect against violence and adversity. This can be done through bystander approaches, engaging men and boys in prevention. We ensure a strong start for children. This includes early childhood home visitation, making sure there's high quality childcare. We teach skills. So this is social emotional learning, safe dating skills, parenting skills. We connect youth to caring adults and activities. This can be done through after school programs and mentoring programs. And we intervene to lessen the immediate and long-term harms. And relative to substance use disorder, this can be family-centered treatment for SUD. Again, engaging the children in those substance use treatment activities. Next slide, please. So last thing I want to talk about before I share a few examples of successful programs is what has happened during COVID-19. So what is this intersection with COVID-19? Next slide, please. So again, this is not good data, I'm afraid, but this is data showing drug overdose deaths for the 12-month period from November 2019 to November 2020. So, first obvious thing here, November 2020 was 9 months ago. Things have not gotten better with COVID, particularly recently over the last 9 months. For that period from November 19 to November 20, the percent change in drug overdose deaths over that 1 year period, they went up by 28.9%. Next slide, please. This is a survey that was published in the Morbidity and Mortality Weekly Report in June of 2020, 14 months ago. Again, things have not gotten better. So during this time period in late June of 2020, 40% of US adults reported struggling with mental health or substance use. Again, a lot of that was attributable to the pandemic. And then the next slide. And this kind of brings it all together. So as a result of COVID, we know that things are happening in children's lives that are placing them at more risk. There's decreased access to basic services. There are fewer preventive resources that can serve children. There's heightened family stress, and there are fewer connections for people to intervene. So we've done some work in collaboration with Marshall University, where we have helped them with doing some community focus groups around ACEs. One of the things that it just still sticks with me, one of the things that we heard from the community stakeholders in the education sector was the quote that we pulled from it was, "Now our children are invisible." So children at that point were being taught at home, they were distance learning, and they were not face-to-face with a teacher who may be able to spot abuse or intervene. And further, they were in a home environment, stuck with family that may not have been a good environment. So things during COVID have not been good for children who experience ACEs, and that's really the bottom line. Let's go on to the next slide. And then one more, please. So this is where I want to share a few positive examples with you. Again, evidence-based models, trauma-informed care, the 4 R's of trauma-informed care: realize the widespread impact of trauma, recognize the signs and symptoms of trauma, respond by fully integrating knowledge about trauma into policies, procedures, and practices, and then resist re-traumatization of children as well as the adults who care for them. Next slide. A couple of programs to highlight. One is Athletes as Leaders. This is a program for high school athletes on girls' sports teams. The program aims to empower female-identified youth into taking an active role in promoting healthy relationships and ending sexual violence. There's a similar program for boys called Coaching Boys into Men. This is a comprehensive violence prevention curriculum and program that inspires athletic coaches to teach young athletes that violence never equals strength, and that violence against women and girls is wrong. And then one more. So the next one is a program in West Virginia, Handle with Care. And again, you can look through this flow chart, which I know is a little bit busy, but the big thing to know here is that it is a cross-sector approach. It engages law enforcement, teachers, school counselors, mental health professionals. It takes an all community approach with everybody working to identify and respond and mitigate and prevent. And that's really, I think, what's successful behind this program. And then last thing I want to end on, I mentioned I would do this, and I think we have a few minutes left. So I mentioned that we have at ETSU the Strong Brain Institute, and I did not want to speak on behalf of my colleagues because they do such a great job with it themselves. So they were kind enough to tape a short video to introduce you to their institute.
Hi, I'm Megan Quinn, faculty at East Tennessee State University and the College of Public Health. And today I'm going to talk to you about the ETSU Ballad Health Strong Brain Institute. The ETSU Ballad Health Strong Brain Institute began formal operations in March 2020 through a gift from our local health system, Ballad Health. This happened to co-occur with the COVID-19 pandemic. However, the development and positioning of the Strong Brain Institute, or SBI, has been methodical and intentional, and we began working together much before March 2020. as a group of BRAIN trustees and associates. BRAIN, we named ourselves as an acronym, Building Resilience Through ACEs Informed Networking. The BRAIN trustees and associates are now considered core steering committee members of the ETSU Ballad Health Strong Brain Institute. We are comprised of 15 faculty and 5 associates and are representative of 11 different departments on campus and 8 academic colleges, which are all 8 academic colleges at ETSU. The Strong Brain Institute also has an external advisory council, which is made up of community members representing different sectors. So we have individuals representing government, legislature, education, healthcare, business, and faith. Our focus in the SBI is primarily on resilience, promoting and building, and less on adversity and trauma. Although we do pay attention to that adversity and trauma and are curious about that, we want to promote resilience and building that resilience throughout the life course. Our vision as the ETSU Ballad Health Strong Brain Institute is to be the preferred resource for promoting the awareness and empirical study of adverse childhood experiences, or ACEs, promoting the development and dissemination of evidence-based practices to prevent, reduce, or mitigate the negative effects of ACEs on health and health disparities, and for promoting resilience and a trauma-informed citizenry and workforce in the Appalachian Highlands region and beyond. The mission of the SBI is to promote institutional and community resilience through science and education throughout the Appalachian Highlands region. That Appalachian Highlands region spans Northeast Tennessee and Southwest Virginia, but we're open to collaboration beyond that area. We are guided by our core values, which are provided here on the screen. These stem from SAMHSA's trauma-informed principles and values that many of us may be familiar with. We want to do this to have our scientific endeavors promote resilient individuals and environments, both in our practice and our scope of study. And we want to emphasize that through safety, transparency, support, collaboration, empowerment, and social awareness. As the SBI, or Strong Brain Institute, we want to promote prosperity on campus and in our community by advocating for resilient communications, policies, and procedure. We also work to create trainings and curriculum. So we want to advance the education of trauma-informed care and resilience building on ETSU's campus and beyond. We also design and implement research to include internal and external grant funding, publications, and project briefs. And we provide community outreach in the form of town hall meetings and webinars and opportunities to gain information. We have lots of collaboration opportunities. So we are a group of basic and applied scientists with expertise in a variety of areas, including ACEs, prevention, dissemination, and implementation. We have created resilience-informed training and certification programs and facilitated town hall events. We also really enjoy connecting the dots and coordinating ACEs efforts in our region and beyond, and consulting on resilience-informed strategies and programming. We also have a skill set in evaluation and consultation in the areas listed below. One of the most exciting things that has come about recently in the Strong Brain Institute is our first training, which results in a badge that you can see below. The yellow badge that says Fundamentals of ACEs and Resilience Level 1 is our first badge that can be received by anyone. And the link there is for our initial training, Introduction to ACEs, using trauma-informed approaches and fostering resilience. Should you have any questions or want more information on the Strong Brain Institute, you can contact Dr. Wally Dixon, our founding director of the SBI, or myself, Megan Quinn, who's a member of both the Strong Brain Institute and the ETSU Center for Rural Health Research. Our website link is below, and thank you so much for taking the time to listen to our presentation.
All right, and if you just go to the last slide, this is my contact information. I don't know that we'll have a lot of time for questions. I'll hand things back to Shai, but please, if anybody wants to reach out, please don't hesitate. We are happy and love to happy to answer any questions and love to collaborate with people all throughout our region.
Great, thank you so much, Michael, for that important presentation on where we are with the opioid crisis, specifically in Appalachia, and the implications for our work. We do have a few minutes for questions and answers. So if you have any questions you want to ask Michael before we move on to the closing session, feel free to type them into the chat, either to the Q&A button or to the chat box itself. So I'll give you all a few seconds to think about if you have any questions. While you do that, I just want to mention Dr. Megan Quinn, who just spoke in the video, is going to be here tomorrow as part of the session of the summit during the 10:30 to 11 a.m. Eastern Standard Time networking sessions. She's actually going to be one of 11 sessions pre-summit as part of the networking. We have some networking sessions before the summit begins. So that's at 10:30 a.m. Eastern Standard Time. And then we'll start the second day of the summit at 11 a.m. So I am still looking to see if any questions are coming in. I don't see any, and we're just on time. So I'm going to thank Michael Mead once more for his great presentation. There's some thank yous also on the chat for you. And I'll turn things over to Nancy Paris for our closing session.
Well, thanks so much, Michael. And hello, everyone. I will be doing our wrap up and next steps in just a moment. I'm just going to switch over our recordings.